Yeah, I think that the key thing is that you're looking for both toxicities, and then obviously you're restaging the disease. And so all of these patients are being treated because they have a life-threatening illness, and obviously one of the worst things that can happen is to have the malignancy progress or relapse or not respond to the therapy. So most patients have restaging of their disease around a month after CAR T-cell therapy. But that doesn't really tell you the whole story. It's really more important 3 and 6 months to determine what's the likelihood that remission is going to last. And patients who have complete remissions that are in the 3 to 6 month range appear to have a higher chance of having sustained long-term remissions. So I think patients need to be monitored for sites of recurrence or relapse. This usually requires a PET scan. And I think you should always be thinking, how am I going to manage this disease if it does come back? And that's one of the challenges that are facing us. In regards to relapse disease, I recommend that patients are followed closely, and if there's a single site of disease that appears to be relapsing, to try to biopsy it. Biopsy is important for two things: one, to determine the histology, but also to look for CD19 expression, because some of these patients can have actually antigen loss or CD19 negative escape variants of their tumor. And in that case, the CARs wouldn't do any further function, and the only approach you really have is to try to treat that with something else. And as far as treatments, after CAR T cells, I like to use radiation therapy if a single site of disease can be targeted, and that's often that can be very effective. Other options would be trying to use a more systemic therapy, and I like to use lenalidomide and rituximab as an anti-CD20 antibody in that setting. Other options would be checkpoint inhibitors such as a PD-1 or PD-L1 antibody, which has shown some success in anecdotal cases.